Thank you for coming to the At-Risk Diversion training. My name is Victoria Lewis. I'm an in-reach coordinator with HICPUF. We are recording today's meeting, so please ensure that you do not share any personal or protected health information, either verbally or in the chat. At this time, the department is not allowing for external use of AI note-taking bots in our meeting without advance accommodations request. If you need accommodations, please email John Barry. His email address is on the slide and he can assist you. In today's agenda, I'll be going over the purpose and project goals for at-risk diversion, the definitions of at-risk and at-risk diversion. We're going to talk about who makes up the target population, how they're determined, the implementation process, what outreach activities will look like, referrals, and expectations for case managers. Everyone will be muted until the end of the presentation, and then we'll open it up for questions at the end. And then there's also the ability to enter any questions in the chat panel, and we'll have somebody answer those. There will also be information on resources as it pertains to at-risk. We'll also put in the chat, I did see Amanda notate that regarding the web-based training, so we'll go ahead and put that link in there as well if she didn't already. We'll have the contact information for the InReach unit as well as, information regarding office hours, additional office hours that will be open for any additional questions, feedback, comments, or concerns. The goal of at-risk diversion is to ensure that Health First Colorado Medicaid members living in the community and that are identified as at risk for institutionalization have the supports and services they need to remain in a community setting of their choice. In 2022, the department made a request to increase funding to proactively support members in the community, remain in the community. And so the proactive initiatives aimed to advance access to home and community-based services. And we had four main areas of focus and improvement in which the department wanted to work on. One was providing additional information to members to prevent unnecessary institutionalization. 2, providing effective transition services. 3, expanding access to Colorado's community-based service system. 4, increasing access to integrated community-based housing opportunities. So the intention of at-risk is to ensure that individuals in the community that are identified as at risk receive a well-documented, cohesive across the state, person-centered process that provides them with support, services, and resources to remain in the community. At-risk diversion will include an additional outreach to support these members in the community with services and necessary supports prior to their need to an institutional admission. Members at risk of institutionalization can have access to transition, case management, transition, coordination, diversion services, which is also known as TCMTC, which I'll refer to going forward. TCMTC is intended to better support members through services and coordination. They provide service planning, they ensure members have support through major life events, and they also support members with housing supports and housing navigation services. TCMTC was previously a service reserved only for institutionalized members. So currently right now, it has changed to members that have been identified as at risk can also be eligible for TCMTC. At-risk is defined as First Health Colorado Medicaid members who live outside of an institutional facility and are at risk for institutionalization as determined by the state. I'll provide a little bit more information on that on the next slide. At-risk diversion is a person-centered process through which services are arranged or provided to enable an at-risk member to avoid admission into an institution or an institution-like setting and be able to live in the community setting of their choice. So the department has been working with the HICPUF data analysis team to identify Medicaid members likely to need for nursing facility care in the near future. This was done by performing research, reviewing published articles and studies. We researched other states' Medicaid programs and similar processes that aligned with what we're doing here with the At-Risk project. We reviewed data analysis, risk scores, and there was testing of several different models. Through this, the department was able to develop a model to determine certain characteristics, diagnosis, and behaviors that lead to an individual's admission into a nursing facility. The at-risk target population is a Medicaid member who lives outside of a nursing facility or other institutional-like setting and is at risk for institutionalization. The target population will be narrowed to individuals with a physical disability or the presence of a co-occurring disability, such as mental illness, intellectual or developmental disabilities, enrolled in Medicaid, and over the age of 21. So some of the other factors will include like lack of caregiver, lack of supports, previous nursing facility stays, multiple hospital stays, chronic conditions, and serious mental illness. Data requests to identify the at-risk population will be requested by the department and distributed by the department. The department will provide the list to case management agencies of those identified quarterly. The members on this list will be members actively enrolled in HCBS, and they will have a case manager already assigned to them. At this time, the department is using this list as its main source of at-risk determination, and case management agencies will not have the ability to make a determination of who is and who is not at risk. The department will establish processes to address any necessary changes to the methodology on how members are identified as at risk based on feedback, experience, and encounters that are reported by agencies that are doing the work. So we do get questions regarding community referrals for individuals that are not on the list. So we are aware of the circumstances that, things happen to people and individuals that put somebody at risk for institutionalization. We're currently working on a second phase and developing an official outside community referral process that'll include specific criteria. We're still working on it. We're still working on the details on how that can and will work. So more details on this referral process will be shared in the near future. The at-risk diversion process. So after the department has identified the at-risk members through data analysis, research, and testing of different models, at-risk lists will be distributed by the department to the case management agencies or the RAIs on a quarterly basis. So members are divided into two different categories. One, if the member is actively enrolled in an HCBS waiver, they'll be assigned to the case management agency. Two, if they're non-HCBS, they'll be assigned to the RAI. So the RAI is going to be expected to do the same things, the same outreach, offer care coordination, offer supports and services, and complete referrals to providers, HCBS, or transition coordination if needed. The case management agency will be notified that the member has been identified as at risk and why the member was identified. The case manager will outreach the member, and based on the member's needs and preferences and availability of community-based services, the case manager will assess the need for additional resources, additional supports and services. Case managers will receive payment for their initial outreach. The department will align deliverables to case management's billing, and more details about this will be shared in the near future. The case manager will also assess if the member has adequate and appropriate stable housing. Documentation of these outreach activities will be completed by the case manager. Documentation will include if there was an addition to existing services, support, resources, or recommendations that were provided to the member as a result of this outreach. Documentation if the member has housing insecurities or lacks stable housing. Documentation of any referrals made on behalf of the member. And the case manager will be responsible to complete any referrals as needed. There will be two types of outreaches, initial and ongoing. The initial outreach will occur the first time the member has been identified as at risk. The initial outreach to the member should occur within 10 business days of the case manager receiving the at-risk list from the department, or once they have notification that the member has been identified as at risk. Ongoing outreach occurs when the member continues to be identified as at risk and comes up on the following list the next quarter. So this will be considered ongoing. The ongoing outreach to the member can occur anytime within 90 days. So the ongoing outreach can be combined and completed in conjunction with a member's next contact or the next monitoring contact. The initial and ongoing outreach can be completed on the phone or in person. Documentation of the outreach and referrals should be completed within 10 business days of the outreach occurrence. If the member is unavailable, the case manager should make attempts to contact and document their efforts in the activity log notes as well as indicating it on their billing deliverables. The member is able to opt out or decline at-risk services and supports during these outreaches. When a member has been identified as at risk and the case manager is notified, the case manager will record the measures that were taken for each at-risk member. Again, documentation needs to be completed within 10 business days that the member was contacted or that the attempts were made. The case manager will complete an at-risk assessment, and it will include a series of questions, the member's community living preferences, any need for housing support, need to reassess or add additional services for the member, and referrals made on behalf of the member that will assist them with mitigating risks for institutionalization. This assessment allows for case managers to easily document their efforts in a clean and concise way. I do want to add a side note that the at-risk assessment does not replace any documentation, updates, or requirements that need to be done by the case manager under their current responsibilities or requirements. Case managers will document in the activity log notes as it pertains to support, services, adjustments made or requested, as well as referrals. We will provide a little bit more specific guidance on this prior to the list being sent out as well. Referrals should be made to other community providers or agencies, such as the RAISE or to offer care coordination or other community-based providers. And I do want to talk a little bit more about TCMTC diversion services. Members who have been identified as at risk can also utilize the TCMTC diversion coordination. Referrals will be made to transition coordination to assist with housing or support navigation if the member is unhoused or has unstable or inadequate housing. The transition coordinator will evaluate also the member's strengths, needs, and preferences, supports, and desired outcomes. They'll complete service planning to develop a plan to help the member meet their goals. They can provide monitoring and resolution to problems. They can also advocate for certain services for the member and provide more hands-on assistance. The expansion of TCMTC diversion to the at-risk population provides direct support to members who may need support through major life events to mitigate risks. Some of these examples on what transition coordination can help with is like housing vouchers, assistance with finding housing, advocacy, collaboration, assistance with community resources, applying for food stamps or Social Security, anything like that, and basically any support for life management concerns. So this project is going to align with this new rule revision under targeted case management transition coordination rules, and it's going to expand the eligibility to individuals that are living in the community who are identified as at risk. As mentioned before, this was previously only available to members transitioning out of nursing facilities, but the department has expanded also housing vouchers and navigation services to address some identified issues. An example of this would be individuals that sometimes go into a nursing home due to lack of housing versus level of care need. But basically, through this new initiative, there was new and more housing vouchers made available for institutional transitions and for the at-risk population members. There will be an at-risk diversion Google form available to refer these members to TCMTC. At this time, the Google form is only available to members identified as at risk. And then we do hope that this is only a temporary and then once it's in the care and case management system, and I'll talk a little bit about that here in a minute, the referrals will be done through there. A link to the Google form will be available in January 2025, and we'll ensure that case managers have that information prior to the first list being distributed. If there are specific questions coming in regarding TCMTC, if there's any circumstances or questions about an individual specific needs, there's also a TCMTC escalation mailbox. Case management agencies are expected to complete all required trainings. Case managers are required to take the corresponding online learning module the at-risk diversion available in the learning management system, and that's what was on that survey prior to us starting. So this training must be completed in the learning management system no later than December 23rd. The expectation is that case managers follow protocols and they'll provide most of the same provisions they already do, such as identifying and assessing for additional providers, as well as additional needs, resources, and supports, as well as completing appropriate referrals. I would like to point out regarding this last statement on this slide, it says on the preferred system for documentation of all case management activity. Currently, there's some delays with the care and case management system, CCM, and we're expecting at-risk not to be in CCM until March of 2025. We will be working on a workaround plan for this first list, which will be distributed after January 31st, 2025. The at-risk list will be distributed to each case management agency's external SharePoint site. Documentation as it pertains to at-risk needs to be in the activity log notes as well as being in the billing deliverables. When submitting an invoice for the initial at-risk outreach activity, we'll provide specific guidance on the information needed for members that were contacted during that billing period. Case managers will document in the activity log notes their contact made, attempts to contact, any addition to existing services, additional support, resources, or recommendations that were provided to the member as a result of this outreach, as well as housing insecurities or referrals made on behalf of the member. The list will continue to be posted quarterly on the case management agency's SharePoint site, even after it's live in the CCM. I do also want to note really quick that the department does plan to implement a smaller list than previously expected. So the first list, we're looking at releasing between 200 and 250 Medicaid members versus the initial plan was to implement 1,000 Medicaid members. And then I also want to point out that 200 to 250 is going to be divided, or not divided equally, but it will be some that are assigned to the RAE and some that are going to be assigned to the case management agencies. This is just to ensure that there's not an overload to the system, or, we want to make sure that there's not any issues or concerns that come up during the execution of this project. And we also want to support you guys that are doing the work, and we also want to make sure that members are also being supported, the ones that are being identified as at risk. So, and then of course there's the CCM job aids that will be available in training resources when it is available in the care and case management system, as well as support with any CCM issues is available. So here are some resources as it relates to at-risk diversion related to the Colorado rules and regs on the transition coordination, case management overall requirements, the additions that were made into the CMA contract, the Department of Justice findings letter, and the informational memo. This presentation will be shared after the training sessions have all been completed. So I'm going to stop here for some questions.
Do we have a payment amount established? And go ahead. I could see you were nodding your head.
No, that's okay. Yeah, I talked about it briefly. I didn't give out the exact amount, but that's a great question. So there's going to be two types of outreaches. I don't know if you heard that part, the initial and the ongoing.
Yeah.
The initial outreaches should be conducted within the first 10 business days.
Mm-hmm.
That one, there will be a payment associated to that. And we actually aligned it with what case managers are already getting for the regular monitoring contacts. So the
Okay,
payment
so
will be
it's a
the same.
monitoring. Okay.
Yeah,
And
it'll
then
just be the ongoing outreach that there's no payment an additional payment attached for it.
okay,
Just because you'll be aligning it with that monitoring contact.
got it. And then my second question is, once we do the second outreach within that next 90 days, are there any other requirements after 90 days as far as monitoring the case in relation to this at-risk outside of the regular monitoring contacts and annual reassessment?
Yeah, so we're going to be looking at the documentation and that at-risk assessment to kind of see there should be a question on there that's going to ask if you think this person is at risk still. Not in those words, but basically the case manager is able to go in there and put like you mitigated the risks or you provided, let's say they were lacking a support or caregiver or something that they were lacking and you were able to mitigate those risks. We're definitely going to be looking at that. um, and then we can talk about it if somebody has, if there's like a, you're kind of like absolute, like this person is not at risk, that is going to be the perfect place to enter that information, and we will be looking at it as we're pulling the reporting. And these
Got
are
it.
quarterly, so we'll have time to go in and look at all these.
Okay. Can I ask another follow-up question?
Yeah.
So let we get our first report this, they get in January, right, for the first quarter. If a client is on the list again for the second quarter, do we restart the whole process and reach back out within 10 business days? And
No, if they show up a second time the following quarter, it's that one you can align it anytime within 90 days. So
okay.
anytime that you're going to be making that next contact or the next monitoring contact. So there's not going to be a certain date set for that. It'll just be anytime within 90 days, if that makes sense.
Thank you so much.
You're welcome.
Yeah, it looks like we have Emily up next for her hand raised. You should be able to talk, Emily.
Yes, hi. Thank
Hi.
you, Victoria. Two questions for you. So the 200 to 250 Medicaid members that you mentioned that will be shared across RAIs and CMAs, is that across the state or okay, not per agency?
Yeah, it's across the state. And like all of you guys know, we'd probably expect those numbers to be smaller in the more rural areas. Um, but yeah, it's going to be statewide.
Okay, great. Thank you. And then my second question was just to clarify, um, you mentioned that in March would be when you're hoping that there will be like an at-risk assessment within the CCM. So between January and March, you're looking to have CMs just log note the supports, but there's not a specific form that they should be filling out with the actions, or is there some type of other document that they should be using?
As of right now, we're just going to provide specifics as what we want documented in the log note. And really, the reason why we didn't want you guys to complete like a form or have it uploaded, and we're really taking into consideration all the work that you guys and all the changes too that all case managers have had to undergo this last year or longer, I'm not sure. But we definitely want to make it as easy as possible. But we will give specific guidance on what we want documented. And it's not going to be anything above and beyond that you're already doing besides making that additional outreach.
Okay, great. Thank you.
You're welcome.
Linda Medina, you should be able to unmute yourself now.
Okay, thank you. Yes, my question is, what was my question? Sorry. So we're being paid separately for at-risk diversion. Are there clear parameters regarding what all falls under that reimbursement for at-risk diversion, and what would be documented as a regular PMPM contact? In other words, will the at-risk diversion eventually be that assessment that's in CCM? Or is it everything that a case manager might do for follow-up, which could be quite extensive for that member?
Hopefully I understand your question right. So yes, it is gonna the at-risk assessment will be eventually in the care and case management system. And just because we want to make sure that there's no issues that, I know you guys probably have already known that there's like a lot of kinks or things aren't working correctly or as they should sometimes. So we'll probably have, and you guys are gonna, in your SharePoint site, you guys will have not only the at-risk list, but also for the deliverables on there. And so once payments are made for that initial contact, it's we'll gather all the information from there. We'll continue to do that for a little while just to make sure that there's no issues with the care and case management system. But once that is, I believe, Chanel, correct me if I'm wrong, that once that's up and going in the care and case management system, we're going to be able to have it being paid once that's completed through there.
Okay, so the payment will be for the assessment, not
Yes.
for everything else that the case manager does to try to help that individual connect with services around the at-risk diversion.
Correct.
Yeah,
Oh, go
correct.
ahead. Go ahead,
Oh, go
Victoria.
ahead, Chanel.
So yes, that's correct. The additional payment will be to support the initial outreach for that at-risk member. And it does include some of that administrative cost on the back end. It is not divvied out separately. And the reason that we try to align or give space to align it with the quarterly monitoring is just because this is a typical requirement for case management agencies to kind of follow up with members and have those conversations. The only thing that we're really doing different is asking for a little bit more documentation in order for us to be able to pull that data as we move forward. So that's kind of what the biggest difference is.
Okay, thank you.
And there was a question in the chat, I'm sorry to jump in, and I felt like it would be better to answer it live than to try and type it all out. So the question was, we're rolling out the first list with a workaround instead of waiting until the CCM is ready. It seems like we are asking for issues to happen. Haven't our members as well as our staff had a struggle enough with computer and program issues? And there was a second portion that just asked, what is the reason that we are working with this deadline versus waiting for the CCM? And so I just wanted to share part of that has to do with the Department of Justice findings agreement. And so I think I dropped that agreement into the chat. And so as some of you may know, we were going through a Department of Justice negotiations. We actually had an agreement that was signed on the end of October, I believe October 31st. And part of that agreement, at-risk diversion, needs to be implemented this coming year, so in 2025. And so in order for us to get the rules together, give us some time to meet that deadline for the Department of Justice agreement, work out our kinks, make sure that you all have time to give us feedback and that our list is working appropriately. That is kind of why we're on the timeline to start earlier than the CCM elements are going to be ready. And so I thought I would bring that to you all as a verbal answer versus trying to type that all out. So I will hand it back over for additional questions. Thank you.
Just really quick, I just want to add to what Chanel was talking about, because I think we've talked about this a lot in other meetings, but when she's talking about the settlement agreement, in March of 2022, the Department of Justice issued a findings letter alleging that Colorado is violating Title II of the American with Disabilities Act, by administrating its long-term service care in a way that unnecessarily segregates individuals with physical disabilities in nursing facilities and places others with physical disabilities at serious risk for unnecessary institutionalization. So that's the beginning part of what she was talking about. But thank you, Chanel, for answering that.
All right, looks like we have one more hand up. Jessica Thayer again.
I know, sorry guys, this just popped in my head. The payment portion, are we going to be submitting those claims similar to how we're doing our TCM and monitoring submissions? Or is it going to be similar to like our 100.2 payment where it's HICPUF is managing that for us?
Now, do you know the answer to that?
So to begin, they are going to be an invoice submitted to us by each case management agency. We've actually been working with Amanda Allen and her team to make sure that it aligns with processes that you all are already using. And so it will be an invoice deliverable. It will have kind of that member information, and then we would have some drop down boxes to collect that data on, like, were you able to contact the member? Were there additional supports provided? Is the member actually considered at risk, either from your perspective or their perspective? Do they want to continue to be on this list in the future? Just kind of those questions, and they'll come in a drop down. So that's kind of how we're working until we have the CCM. And then once we have the CCM, our hope is that we can pull a report to see all of the at-risk assessments that have occurred and then make payments based on that. And I apologize. I thought my camera was on that whole entire time. Sorry.
No, it's okay. Thank you. That makes sense.
And we have Jacqueline. Her hand is up. And Jacqueline, you should be able to ask your question when you're ready.
Okay, so when we come across somebody who is on this list, right, we as the service coordinators who are responsible for the quarterly contacts need to reach out to them within 10 days. If it happens to be during a month that we're required for a quarterly contact, also just log notice separately, right? And then I'm guessing that we're going to be told to, put this conversation down as a specific drop down as far as case documentation or at risk or labeling it a certain way, I'm guessing. But when it comes to the actual assessments that you're talking about, I think I'm getting a little bit lost here. Are the service coordinators that are responsible for the quarterly contacts doing the assessments, or is the transition coordinators doing that once we refer to the transition coordinators? Who are the transition coordinators?
So really quick. So I know when you hear assessment, you're thinking of this long assessment. And I'm sorry, I didn't clarify this prior to. It's probably about, I think, 7 or 8 questions. So it's not a full assessment. They're just going to be questions like, does the member have stable and adequate housing? Yes or no. If they don't have adequate and stable housing, that's probably when you want to, because they're going to be identified as at risk, is when you can offer that transition coordination referral to help them find housing. So there'll be other questions like, did you provide additional supports and services from this outreach? Does the member, I can't even think right now. I know there's like about 8 questions around, and it's like a yes or no. So it's not like a full assessment, if that makes sense.
All right. And then if those 7 or 8 questions, which again, when we're doing our quarterly contacts, I'm guessing that there's a lot of redundancy there because we ask a lot of those questions during our quarterly contacts with quality of life and all that. So then if it's coming up as a red with that, then we'll move along and do a referral to the transition coordinator, particularly for housing, if that's a situation. And then, so to kind of go along with that, I don't know about with other agencies or not, but a lot of the people that I get that like the conversation ends up talking about a nursing facility, it's usually either they're at home and their level of care has basically gotten to a point where they're wanting nursing facility, or they're in an ACF and their level of care has degraded to a point where a nursing facility would be appropriate. In those situations, I'll be honest with you, I'm not typically going out of my way to overload with a bunch of other in-home services. I'm giving them the information and do the appropriate referral to the nursing facility team to get that ball rolling there. Are you still going to want that same assessment done where we're just kind of answering the questions as though,
No, there is a question specific to that. So
Okay.
it will ask about that. And of course, like, we don't want somebody to be placed or remain in the community if they're unsafe. You guys know your job and you know what you're doing. Like, if the member's not safe, of course, do what's in the best interest for the member. We've just noticed, or not noticed, but there's been instances that have came to our attention, especially through this lawsuit, where somebody didn't have housing And instead of like that, versus like the level of care need, it was more of a housing issue. And that's why they were kind of put into that nursing facility situation. So yes, definitely, what's in the best interest of the member and safety first.
Okay, so this isn't a reflection on if they're wanting to or not, or if their level of care truly is, that's the same process as it's always been, right? Nursing facility team, referral, new PMIP, all that fun stuff. This is more
Correct.
when there's other
Correct.
stuff kind of surrounding that. Now, with that being said, I'm not going to drop names or anything, but I've got one client that we've been working with for a little while here that she is kind of just right on that fence on LOC even being appropriate for nursing facility. This is one where her situation really is more of a housing thing, and she's wanting to use a nursing facility as an housing solution, even though that's not really appropriate, in this situation. But a lot of the conversations that we've had with her is like, hey, here's our community resources, here's a number to the housing authority. And is that like how in depth are the transition coordinators going to be doing that? Because as unfortunate as it sounds, a lot of things I think that we do tell our clients is, like we don't do community housing here at TRE. We do ACF, we do SLPs, we do nursing facilities, but no, I can't assist you with getting on the Section 8 housing list. I can't make that call with you to Gratio. I can't, you know what I mean? So we give them all these resources and they do or don't, they do with it whatever they will. But is that something that the transition coordinator is going to be coming into? Like, are we to a point now where we can say, hey, we can actually assist with non-waiver housing options?
So just to really quick, members that are deemed at risk, so members that are on these at-risk lists are the only members at this time that could be eligible for the transition coordination diversion services. And then,
Oh,
yes, to answer your second question, they do that more hands-on work. They can advocate for the member. They can go talk to the landlord. They can go help them find a house. There are housing vouchers available for them. They can help them fill out applications. So it is more that hands-on work. And
they
they
can do a
don't
lot more in
only
depth
help
than
with
we
house.
can.
I'm sorry?
So they can do a lot more in depth than we can. Okay.
Yes, they do also just really quick, they do like monitoring and follow-up activities. They can go to the home, they can provide advocacy, they can help them like apply for food stamps, apply for Social Security, apply for whatever benefits. Trying to think what else.
Sounds like
Basically any
basically
major
complete
life
like
event.
wraparound. Yeah, no, that's awesome. So,
Mhm.
but if I'm understanding what you were saying at first, though, like this isn't something that we should just be kind of like putting out there to just like they have to be on this list. They have to be
Correct.
identified by the state first, and then we're being notified and taking it from there, not the other way around.
Correct.
Yeah.
And that was something I did kind of talk about a little bit earlier is that, that is like a second phase that we're working on because we are aware that there are circumstances that put individuals at risk. And we wish we could give housing vouchers and we wish that we had this service available to everybody. But unfortunately, we're trying to come up with like a process, criteria and details on like a community outside, like for agencies to refer or a person to refer themselves. We're
But
not
for
there
now,
yet. We haven't worked out the details, so more to come on that. I understand. I mean, I think we get that question a lot, so thank you for bringing that up.
We have Lisa.
Yes, hi. I may have missed something, but I'm hearing kind of different things, so I want to clarify. Are we saying that these additional wraparound services that we can do for the clients that are considered at risk, is it the service coordinator that currently is already overworked and doesn't have enough time to take their coffee break? Are they going to be doing these additional tasks, or are you saying there's going to be a transition service coordinator that's going to be doing these additional tasks? Because that's where I'm like a little bit confused.
So two different things. So we're gonna work out a smaller list in the beginning. Like I said, we're gonna look at 200 to 250 members, and those are gonna be going to case management agencies and RAIs, and they're the people that are identified the highest at risk or um, identified as maybe needing nursing facility assistance in the near future. Those individuals, if they're on a HCBS waiver, they'll be assigned to the case management agency. If they're not on a waiver, they'll be assigned to the RAI for care coordination. And yes, we are asking case managers to do outreach. Like I was saying, that at-risk assessment, ask a few questions, ask, if they need additional supports and services, and see if they have stable housing or, make sure that their housing situation is okay and they don't need supports with that. If they do need more hands-on, intensive wraparound services, or let's say they do need assistance with housing, they need they're homeless, or they need some housing support, then those can it's a referral to transition coordination, the diversion services. So transition coordinator will help with those more in-depth hands-on things.
Great,
That
thank
answer
you.
your question?
Yes, it does. Thank
Okay.
you.
And Linda, Medina.
Okay, can you hear me? Yes, all right. I kind of a follow-up question to an earlier one. So if the referral is for a younger person and that person is requesting nursing facility, let's say they're 35 years old, from the co-learn training, it appears that if the person is wanting nursing facility, then we should support them in that endeavor. But this, a younger person would not be appropriate for that. Would we be in error if we do not support them with that, but try to encourage them to look at other options?
Maybe meeting nursing facility level of care.
Everybody that we,
Well, yeah, that's true, because the waiver services.
yes,
Well, I think if there's like extreme circumstances where it's somebody specific, and remember, these are lists of people that we're giving you guys. These are not just every single Medicaid member, every member that's on a waiver that you're working with. You could, I'll, in a little bit in the next slide, we have the mailbox for escalations. And I think, Chanel, if you can put that on the chat too, we're able to, answer any of those specific questions if it's like member specific. I don't know the whole circumstances, so I'm a little
well, and
hesitant to answer that, but we definitely want to look at safety first.
sure, and this is hypothetical. I don't have somebody in mind, just because that's what the pre-training seemed to be encouraging, I'm asking. Also, I was concerned that the woman with Down syndrome who was the sample in that training, the result isn't realistic here in Colorado, and it's not clear how she would have been identified because it doesn't appear that she was coming to the attention of anybody by being admitted to the hospital or anything like that. And other than the case manager being aware that her housing situation was unstable, I'm not sure how she would have been identified as an at-risk member.
I'm not too sure I understand, or I know what training you're talking about. For this one specifically, our data analysis team were able to look at different variables, different risk scores. We did some research, and we were able to pull like some risk factors, basically, that what makes a person at risk, and we narrowed that poll down and pulled the top 1,000 members, and we're going to narrow it down some more and narrow it down to the top 200 to 250 members. So I understand what you're saying, that the case manager is the only person that knows this person has housing insecurities, but for right now, we're only looking at the people that come up on this list.
Okay, I was just, she was in the training, and so I was curious about what criteria you were using to identify at risk. That's kind of my big question, and I haven't been hearing any answers. So just trying to dig a little deeper.
Okay, yeah. So through the model, they looked at certain characteristics, certain diagnosis, behaviors that could lead somebody, into a nursing facility. We also are this target population is gonna be individuals with physical disabilities. They can have a presence of a co-occurring disability like mental illness, intellectual or developmental disability. They must be enrolled in Medicaid, over the age of 21. Some other factors that we're looking at for identification, they're gonna be lack of a caregiver or lack of supports, previous previous nursing facility stays, multiple hospital stays, chronic conditions, serious mental illness. I believe we're looking at like stroke and people with dementia and things like that. And so those are like the main factors that we're looking at for identification. And then we'll pull the top pool of numbers of those candidates that fall on that list.
And then I was just going to piggyback. So the training that I believe Linda was discussing was the web-based training. And Victoria actually supported it. I knew you'd get it as soon as I said it.
Okay.
Victoria actually supported the development of that training along with our web-based training team. And so, as she said, the methodology for pulling a member is still in the works. We actually have submitted it to our monitor for the Department of Justice. And as soon as it has come back approved by that monitor, it will be posted to our website. And we will make sure that it's shared out to everyone so that you all are aware of the very specific details. I know that's something that's come up a lot of like, how are you identifying these individuals? Where is this information coming from? And so I believe she said it in the slides. It's really our data team within the department did a lot of literature review, looked at different states that use some of the same criteria. Probably in early 2022, our department director reached out to stakeholders and asked for a survey on what did they think were situations or criteria that would put somebody for at risk of nursing facility placement. So we've kind of been working on this for the last couple of years. But as we cannot share or put it out publicly what that criteria is until the approval from our monitor with the Department of Justice agreement. So that is kind of where we are with everything. But as soon as it is completely approved, we will have that out for everyone to review and make comments. And I believe Victoria also said that this is not an end-all be-all methodology. We do want to hear your feedback. We want to know if you think somebody is at risk based on this methodology. We want to know if they think they're at risk based on this methodology. And we do have opportunities to change and update it through the Department of Justice agreement as we move forward. And I don't know if that was helpful, Linda.
Any information is welcome, so thank you, yes.
Yeah, thank you. I'm sorry. I totally forgot about that when it's training and I was just talking about it.
So we have just a quick time check. We're about 7 till the hour. We do have 3 more hands up. But Chanel, I wanted to give you the opportunity if there's anything from the Q&A questions that you wanted to like bring to everybody, feel free to do that as well, or answer your questions. I just wanted to.
No, yeah, that's perfect. I was trying to get through all of them. Thank you all for your patience and continued to throw them in there. I think some of the ones I haven't got a chance to get to yet is what is the plan to ensure that rolling out this early doesn't harm the members due to starting a process we're unprepared for? And so from the department's perspective and our team perspective, we've been really working on this ongoing for about 2 years now. We do apologize that it's kind of been a later introduction to you all as we've gone through negotiations. So we believe that the process is ready and prepared to share with members. We would not be in a place to kind of implement this if we weren't comfortable that it would be helpful to members versus harming them. but we are open to hearing if there's any feedback, either moving into implementation or after implementation, where you all are seeing that this is a concern. Victoria is hosting ongoing work groups, and those are coming out in the case management, what is it called? The case manager's newsletter, for dates there. And then it's also on the memo that will be coming out soon, the operational memo. So that's kind of where we are with that one. Does the at-risk determination take the place of any other waiver members have? And so the at-risk determination is separate from any of the waivers that the member is on. So the at-risk determination is really just looking at the data that we were able to pull from our data team. And these individuals are already on a particular waiver, and that is why their support will come to you. But it doesn't have to do with like changing a waiver. The only time that you would need to have that conversation is if you and the member deem that the member is able and approved to switch to another waiver. And that is their desire. It doesn't align or have to do with them being on this at-risk list. And then, sorry, I think that are all the questions. And I believe we have about 4 minutes left if there's anything else. And we dropped our contact information in the chat along with some web links and the Department of Justice website and the informational memo. So.
Hi, this is Wendy. Can you hear me? I just have a question regarding the transition team. I heard referenced if there are additional steps that need to be taken for a process that needs further help to lean on those transition coordinators. Are those transition coordinators folks affiliated with HIPAA for case management agency staff? Because in rural Colorado, we don't necessarily have transition staff that would be able to jump in and help with that process.
Glad you asked that question. So, transition coordination is actually available statewide. So if you do get somebody on this list and you do a referral to transition coordination, even though there's not one specifically in that rural area, you send the referral still, because we're going to have a Google referral form. You send the referral and we'll get it assigned to a case management agency that's willing to accept that case. Granted, depending on how far it is, they might not be able to drive out there, but they can probably do something like virtually with the member or on the phone, or they'll figure it out. But transition coordination is actually available statewide. And then I think somebody asked in the chat earlier about that. And yes, in January, we will release that Google form, that link. But again, it's only for members that are identified as at risk for right now. Okay, so we're about time. So I'm just gonna really quick finish up. Chanel put all the contact information in the chats. The last thing, right here is the office, the office hours we have scheduled for December 10th, 12th, and January 21st. Starting in February, I actually was not able to put those 2 office hours into this newsletter that's going to be posted, but it will be posted at the end of December with January, and we're planning to have one in February and ongoing, like an exact day of the month and time. We'll have that like ongoing. But also, if there's anything immediate that comes up, you can always reach out to myself, Chanel, or our InReach unit, and somebody will get back to you. And I do want to just point out really quick that this is a new process that is first of its kind, really, in the sense of using methodology to target members specifically, that we know of. It's kind of like first in the nation. We have researched other states, but we haven't found anything that's really kind of like what we're doing here in Colorado. But the department also wants to be responsive and partner with each of you as changes are being made. The department will continue to review and evaluate ways to improve accuracy, ensure that members most at risk of nursing facility placement are being reached. We're excited to pilot this endeavor with all of your support, and I do want to thank everybody for attending today's training.